Okay, great. Okay, welcome everyone. Good afternoon, and welcome to the weekly seminar series here at the Dahdaleh Institute for Global Health Research. My name is James Orbinski, and I'm the director of the Dahdaleh Institute for Global Health Research here at York University. And I'm delighted to host today Amrita Daftary and her team, who she will introduce. And they are going to be speaking on how we can end tuberculosis by shifting attention to the structural drivers of tuberculosis. Now, before we begin, as is our usual practice, I'd like to begin by acknowledging the Indigenous land that we are on. And as this is a hybrid event, some guests are on different physical territories, so please do take the time to give thanks and also respect to the land on which you are currently physically located on. And today I'm here at York University campus in Toronto with the people assembled here at the Institute. And we're situated on the traditional territorial area known as Takaronto, and we acknowledge its current treaty holders, who are the Mississaugas of the Credit First Nation. We also acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and of course the Métis. And this territory is subject to the Dish with One Spoon Wampum Belt Covenant. And this is an agreement to peaceably share and care for the Great Lakes region. And with that land acknowledgement, I'd like to begin with a very brief introduction to Amrita. Amrita is a wonderful colleague of mine and of many here at York, and she's an associate professor of global health at the School of Health Policy and Management here at York University, and she's director of the Social Science and Health Innovations for Tuberculosis Center or Lab here at the Institute. And she draws on, in her research, she draws on qualitative and mixed methods and on implementation science and evaluation, and as well community and gender-based approaches to better understand how to effectively contain, control, mitigate tuberculosis. And she studies healthcare behaviors and caregiving practices for tuberculosis and the social structures of TB programs that guide interventions and related policy responses. She's well cited for her work on the structural drivers of stigma, of gender inequities, of research-driven advocacy, and efforts to center tuberculosis policy decisions on patient needs and priorities. And also, she's very well cited and genuinely an expert on working with communities affected by tuberculosis and by the relationship between tuberculosis and HIV, or what we call TB-HIV comorbidity. She has many publications which are really outstanding, and we're so happy that she's joined us here at York. She's a relatively new hire, a relatively new professor here at York, but her academic background is really outstanding and very much focuses on the social causes and conditions and the societal determinants of health as they relate to tuberculosis. And so some of her publications, I'll just cite two. She's published in The Lancet a year or so ago on the dynamic needs and challenges of people with drug-resistant tuberculosis and HIV in South Africa, and this is a qualitative study. She also published 2 years ago in the International Journal of Tuberculosis Lung Disease, which is probably the signature academic journal on tuberculosis, on TB and women, a call to action. And so with that, I just also noted that Amrita is nominated to the inaugural list of Canadian women leaders in global health, and it's a nomination I hope that will lead to formal appointment. I can't imagine a better woman leader in global health than Amrita. And with that, I'm going to turn it over to you, Amrita, to introduce your team and to go through the seminar. But before you do that, just a couple of quick reminders. It's a 1-hour seminar. We will end promptly at 2 o'clock. People have many obligations and so on, but we will end promptly at 2 o'clock. We'll start with about a 45-minute webinar facilitated by Amrita, and then a very brief Q&A. And I will wrap up very tightly at 2 minutes to 2, just so you're aware, Amrita. And for those online, please note that this is being recorded. And please mute your microphone unless you're presenting or asking a question or engaged in discussion. And then also, I would just encourage those online to use the raise your hand function at the bottom of your screen if you want to ask or pose a question. And with that, I'd like to invite Amrita to begin. Over to you, Amrita.
Thanks, James. Thanks for your generous introduction. That's very kind of you. And thanks again for hosting us, both SHIFTB and this webinar for today at the Dahdaleh Institute, and all the support that you've shown us. Much, much appreciated. So welcome, everyone. I'm really, really excited to welcome you to this World TB Day webinar, which celebrates the social science inspired research and actions, which sort of weighs attention to some of these hidden or less prioritized dimensions of TB when you think about the mainstream responses. I'm joined here by my colleagues, Nora Engel from McMaster University, who is also a director at SHIFTB, and Jeremiah Chikavor at the Human Sciences Research Council in South Africa, who is also a director. And the three of us sort of began this adventure a few years ago with the support of Dahdaleh Institute and others. Nora, do you want to say a quick hello?
Hi, everybody. So nice to be here. I'm an associate professor at Maastricht University in the Netherlands, and I'm using social science methods to study innovation and new technologies in TB control. Looking
Thanks,
forward to the
Nora.
webinar.
Jeremiah, do you want to say a word? Oh, maybe not. Jeremiah, are you on mute?
My apologies, Amrita. I was just disconnected. So can I just catch up very quickly on where you were, Amrita?
Yes, please. I was just asking if you wanted to take a moment to just introduce yourself.
Certainly, Amrita. And good afternoon, everybody, and good evening and good morning in the different places you are at. My name is Jeremiah. I am at the Human Sciences Research Council, and I'm a sociologist. I've been working in the field of TB for the last maybe a decade or so, primarily in the field of men and masculinity, which is a field that I to apply across different areas of health. And I'm very excited to be working with Amrita on SHIFTB and Nora and all the other colleagues. So thank you so much. It's a pleasure to be here.
Thanks, Jeremiah. Okay, so let's move on. So for those of you who might be maybe a little bit less aware about the global situation of TB, it's an infectious disease that is affecting over 10 million people a year upon year, and claiming the lives of nearly 4,500 people a day, despite it being preventable and curable. So this week, this moment in time is typically a time when those of us who work in TB tend to sort of amplify attention to TB, raise global awareness around it to stimulate some sort of transformative action. You know, because it is preventable and curable and still remains one of the leading causes of death due to a single infectious agent before COVID, it's continuing after COVID. It's needless to say that this is a persisting pandemic that is somewhat related to a result of grave injustice in political commitment and financial investment. And so the theme of today's World TB Day sort of webinar falls in line a little bit with what the WHO has sort of talked about. Yes, we can end TB, that's their theme. And the idea is to inspire hope, encourage high-level leadership, investments, uptake of the latest and tremendous new tools and recommendations, and multi-sectoral actions to sort of combat TB. But those of us who work in the social sciences with TB-affected communities and civil society partners want to ensure that all of those actions uphold principles of equity, human rights, community leadership, because historically some of the responses in TB have not necessarily prioritized those ideologies. So with that in mind, I welcome you to the next 40 minutes or so. I'm really delighted to introduce you to one agent of change in this regard, Kelsie McGregor, who is a policy analyst in health at the Assembly of First Nations. Kelsie is an Anishinaabe Cree Ojibwe women from Whitefish River First Nation on the north shore of Lake Huron and is from the Crane clan. She received her BA in psychology and health sciences in 2019 and then a master's of public health from Western University. Prior to joining the Assembly of First Nations health sector as a policy analyst, Kelsie worked at the community level within First Nations health research, health promotion and prevention and policy. She's going to share today some highlights related to TB prevention and treatment in Indigenous communities in Canada, drawing from the latest Canadian TB standards, which is essentially the go-to resource for managing TB in all of Canada. I will then introduce my subsequent speakers, Stephanie and Pushpita, before they take the stage. But without further ado, I pass the mic over to Kelsie.
Yeah, thank you so much, Amrita. And let me just put on my presentation up here. There we go. Awesome. So hi, everyone. Good morning, good afternoon, wherever you are. I'm very honored to be here. And thank you again to Amrita and her team for inviting me to speak in honor of, I guess, in recognition of World Tuberculosis Day. My name is Kelsie McGregor, and I'm from Whitefish River First Nation, which is just off the shores of Lake Huron. And I am currently still living in the area right now. I'm a policy analyst with the Assembly of First Nations, and I also have the pleasure to have my colleague Marlene LaRock here as well, who had helped develop these standards that I'll be presenting on today, and she'll be able to answer any questions or comments that you have at the end of the presentation. To begin. So just a little outline of what we'll be going over today. First, we'll look at the epidemiology of tuberculosis among the 3 Indigenous groups in what is now Canada. After that, we'll look at the First Nations experience specifically with tuberculosis, and then we'll highlight the standards from the Indigenous chapter and underscore the 7 good practice statements that came out of that work. And so first looking at the current epidemiology in Canada, so Indigenous Canadians represent just under 5% of the Canadian population, but are 19% of all tuberculosis cases in Canada. And so this just under this 20% is Indigenous populations, and then the vast majority of the other cases in Canada at 71.8% come from the foreign-born population. So First Nations specifically make up are just about 1 million people in Canada, with the majority living in urban or rural areas or on these just over 600 First Nations reserves in Canada. And so for First Nations, they make up 37.6 times, they have 37.6 times the rate of tuberculosis compared to the Canadian-born non-Indigenous population. Inuit people, so they make up about 65,000 of the population in Canada, and their rate of tuberculosis is much higher, at being about 400 times the rate of the Canadian-born non-Indigenous populations. And then finally, Métis, which are about 500,000 Métis in Canada, majority in Ontario and the Western provinces have about 7 times the rate of tuberculosis. And so looking at specifically the First Nations experience with tuberculosis, beginning pre-contact, so before settlers came into what is now the Americas and Canada, First Nations people had their own governmental laws, systems, diplomatic relationships, cultures and languages, and many of their ceremonies practiced environmental sustainability and just wellness overall. And so it's at this point in time that TB did exist in the Americas, but cases were sporadic. Going to post-contact, so when settlers begin coming to the Americas and Canada, and then going to the late 1800s, in the beginning, there was economic trade and this nation-to-nation diplomacy between First Nations and settlers. However, over time, we do see this deterioration of respect and for First Nations, for their cultures and their practices. And there's further land encroachment and overexploitation of the land and natural resources. And so from this time, from when settlers come to the late 1800s, there is much more exposure to not only tuberculosis, but other illnesses, and then possibly the more violent strain of tuberculosis was introduced from there. And then looking at the late 1800s on, we see that deterioration in the relationship really take place. First Nations go from being allies of Canada to wards with the treaties and the first with the Indian Act put into place, which abolished the governmental systems, culture, practices, and languages, making them illegal. They're forced onto reservations, encampments, and there's a lot of just social determinant of the health that just kind of really decimated the health and wellness of First Nations. And so it's at this point TB cases just really surged, and there were countless deaths as a result. And so it's at this point that residential schools and Indian hospitals were put into place as well. And so these institutions just overall had poor ventilation infrastructure design. We know that the healthcare, the food, everything was just subpar compared to what was needed. And so it's in these institutions that about a quarter of the students would die from tuberculosis, and the awful treatment that they faced led to resentment, suspicion, and distrust towards government and medical systems overall. And it's not that governments and healthcare institutions didn't know the link between these institutions and poor health outcomes. This paper in the middle by one of the chief medical officers, I believe, Dr. Bryce, had made that link at the time in the early 1900s, but the report was largely ignored by officials. And so now going to more current history, in the 20th century, we could see First Nations deaths and case rates actually do decline, but this does coincide with just better access to diagnostic tools, treatments, vaccines. So it is not just the improvements into medical care, it's also, we see the amendments into the Indian Act. So towards the 1950s, Indigenous First Nation people are allowed to practice their culture. They're allowed to participate in the legal system and vote into federal elections, and there's the removal of that compulsory enfranchisement. And so, and then today, in looking at today, where we are right now, so First Nations TB rates have been stagnant over the past few years. And so, like I said before, we have about 37.5 times the rate of tuberculosis. So that's where we kind of stand right now. And so it's kind of evident in if we look over the history that that the rates of TB and illnesses were parallel with the racist legislation put against Indigenous people and First Nations as a whole. And as we begin to repeal those and move towards reconciliation, we see improvements, but there's obviously a long way to go. And so looking specifically at the Indigenous chapter of the TB standards, so this, as said before, this is one of the the highest standards for tuberculosis for those working in the area. And so in anticipation of the 8th edition, rather than focusing on just the medical and research and literature, the authors wanted to reach out to Indigenous peoples and organizations to identify what their priorities are and what we think should be focused on, in addition to the medical science and research that is typically in these in the standards. And so from the onset, the Indigenous groups, so Assembly of First Nations, ITK, and the Métis National Council, they voiced that the context, specifically history, culture, and epidemiology of each of the Indigenous groups is central to be able to understand and care for individuals with TB, because TB does not stop after the prescription is written. So although we understand that TB for Indigenous people may have been a result of colonization, it's not enough to simply write prescriptions. We need to look at all the other determinants of health as well to be able to properly care and understand for our people. And so again, the overarching themes were looking at the epidemiological factors, the historical and cultural context, and then now moving on to a path forward. And so in writing those objectives, they kind of developed these 7 guiding principles for healthcare workers to consider and to use when working with Indigenous people for tuberculosis care. And so I'll just go quickly into these 7 these good practice statements. So number 1 is having healthcare professionals educate themselves about the epidemiology of TB in the community, recognizing the community's historical relationship with TB. And so it's not enough to recognize just First Nations as a whole, Inuit as a whole, Métis as a whole. It's also the community you're in, because each community, whether it's rural, urban, the way colonization has affected each community is vastly different. So it's a matter of connecting with that community and understanding exactly where they are. Next to that is understanding the geography and climate of the Indigenous communities, and understanding that the isolated rural lack of healthcare access and can lead to delayed treatment and diagnosis of TB. Number 3 is acknowledging the Indigenous territory that's one's occupying, and understanding and practicing culturally safe and self-reflection on power differentials and respecting their cultural differences. Number 4, there we go. So recognizing the specific social determinants of health affecting distinct Indigenous groups with the aim of delivering quality TB care and closing the health equity gaps. Acknowledging the role of ongoing colonization, personal and systemic racism, and privilege as a result of healthcare equity in tuberculosis care. Number 6 is promoting self-resiliency, advocacy, and empowerment by respecting the rights of Indigenous peoples, as outlined in the Patients chapter of TB care and under United Declarations on the Rights of Indigenous People. And finally, understanding that each group, First Nations, Inuit, Métis, is historically, culturally distinct and have unique TB needs. And in addition to number 7, it's not understanding each distinct Indigenous groups, also the different nations that you're working with and specifically where they are. And so these 7 good practice statements can be categorized into these 4 categories. So number 1 is knowing the community you're working with, recognizing the barriers, whether it's the social determinants of health that are currently affecting the community or the previous effects of colonization. The next one is respecting the self-determination of the community you're working with, of the people you're working. All right. And then number 7 is acknowledging the cultural differences between the Indigenous peoples of Canada and the different nations you're working with. And so from this work, we got these outlines of priorities to be able to move forward in our work to, like the theme of this year's World TB Days, and end TB or stop TB. So there is a need for timely, up-to-date, and reliable data to track TB performance indicators. The statistics I had given you at the beginning of the presentation, I believe, are close to 5 years old. So it's difficult to know where we need to make changes if we don't have reliable data. We need to promote Indigenous workforce development to help address health human resources in communities. And that also helps with culturally competent care when you have your own people working in their own communities. There's also a need for relationship building. There's the call for rifapentine to be submitted for regulatory approval. Right now, it is only accessible through special channels, I believe. Next is recognizing and addressing the connection between the housing crisis and TB, and additionally all other social determinants of health. And then finally, having resources that are distinctions-based for tuberculosis elimination efforts. And yeah, so the conclusion, this is just what we went through today. So looking at the different epidemiology for the 3 Indigenous groups, looking at the historical and cultural context for tuberculosis in First Nations specifically, looking at the standards approach, and seeing the work that came out of the 7 good practice statements and the priorities that were identified. And so, yeah, thank you. These are acknowledgements and the great people who put the work into developing this chapter. And I believe that is all. So yeah, thank you so much. Perfect. And I
Thank
believe
you so much.
Awesome. And I believe Marlene is on as well. So if there are any questions about the standard, she can definitely answer them for you. And so
thank you.
Kelsie, that was a great presentation. I just want to apologize for that Zoom bomb.
Oh, no worries. I worked with youth before, so I can take that in stride.
Well, I'm sorry it happened, but it was a fantastic presentation. So back to you, Amrita.
Yeah, thank you so much. I just want to apologize to Kelsie, Marlene, and everyone else and all the other speakers here for that. I believe the Institute administrators are handling eliminating unwanted people. So thank you. Kelsie, what a fantastic, fantastic talk. I welcome everyone to please put in some questions and comments into the chat box. Marlene and Kelsie, maybe we can take a couple of questions and then move on to the next 2 speakers before we have a more elaborate group discussion. Any questions for Kelsie or Marlene? Well, I have a question and a comment. Oh, let's see. Nora, dear Kelsie, this is such exciting work. I'm not so aware with the policy in Canada, but do you have an idea of how implementation could work and what would likely help to realize these important aspects? Will they somehow be measured, accounted for, which could help budget for it? I guess I'm asking about translation into practice. And that's from Nora Engel, who's a co-founder of SHIFTB and currently based in the Netherlands.
I don't have an answer for that, but Marlene might have one for you.
Yes, good afternoon. I'm just going to try to turn on my camera for this. It's more important that you hear me than see me, but here I am. I'm Marlene Larocque. I'm Cree from Waterhen Lake First Nation in Northern Saskatchewan. I work at the Assembly of First Nations. Yeah, so most of these good practice statements, like this is really foundational work, and it's really directed at healthcare workers to provide culturally competent care. There is a lot of stigma. First of all, there's a lot of racism and discrimination against First Nations in Canada, particularly in the healthcare system. And one way of addressing that and making things better for First Nations is to have a culturally competent workforce. And it doesn't necessarily require great investments, great monetary investments, I think, but it's really up to associations, faculties of medicine, schools, nursing schools, etc., to really implement some of these some of these good practices. And these are like already developed. You don't need to go out there and look for something else, but these are already developed and they're really practical. But then, so that's just one part of making TB care more culturally competent. But there are structural issues, underlying structural issues for First Nations that really lead to the spread of tuberculosis, such as overcrowded housing, food insecurity, income insecurity. I'm preaching to the choir here, but the social determinants of health really need some action and some attention. Thanks.
Thank you so much, Marlene. Nora is saying a thank you. She's just multitasking because it's evening and the kids are home. But thank you so much for that. Any other questions or thoughts or comments? I just wanted to say, it's to me, I've been studying this a little bit, and it's quite exemplary, and it's really quite unique in the TB space to have a chapter such as this embedded into a clinical guidance. We often have these little like patient-centered care or community-centered approach documents that exist in parallel somewhere in the universe of clinical sort of management of TB, but they're almost never embedded as recommendations or action points within standard guidelines. There'll be like a little bit of mention that there are certain people in certain communities that we need to be mindful of, but there's never an action requested of that, and so I feel that some of this and some of what Nora has commented on could lead to some accountability and hold some answerability to seeing if the TB response in Canada can actually realize some of these commitments. And I'm sure many of us might be involved or at least have heard about the United Nations high-level meeting on TB that's coming up this September 2023. And that's going to be kind of a moment in which all actors are just going to be galvanized, or at least there's going to be some momentum to speed up attention to TB and sort of, say, that's it, that's enough. We got to end this present day pandemic. And it's through actions such as this that we can actually, achieve this goal of reaching all and enabling equitable access and all these broad ambitions that we have that sometimes don't get translated because such concrete actions that yourself, as on behalf of the Assembly of First Nations, the Inuit, as well as the Métis community has come together to do in Canada. So, a huge applaud to you and thank you for presenting today.
Thank you so much.
Amrita.
James.
Oh, sorry. Yeah, we have a question here in the Institute. So, Imran, do you want to go ahead?
Yeah, sure. Well, thank you so much, Kelsie, for a really fantastic presentation. I learned so much from it. What I really took away from it was how clearly you laid out the trajectory and change in TB amongst First Nations communities with the changing political and social factors of colonization and the beginnings, the inklings of maybe decolonization leading to this kind of stagnant level where we're at. And thank you so much also to Marlene for pointing out like the needs in treatment and healthcare systems for the treatment of TB and the social determinant of health for preventing TB. I think that ties together really nicely here because I'm trying to formulate the question as I speak, so forgive me for being kind of all over the place here. As levels are stagnant of TB, and we see this very clear kind of movement together, TB rates with forces of colonization, what will it take to get TB levels down? Like, what does the decolonization process look altogether with respect to health systems, sovereignty, self-determination that would yield that goal of elimination of TB from your perspective?
Yeah, so I think that's a very difficult thing to answer. Mostly, one of the things in the good practice statement is understanding each community's, like in each nation's own history, and recognizing their self-determination into making those solutions from themselves. So I think one of the things about decolonization, it's a matter of asking the communities or the nations that you're working with and allowing them to find allowing them to kind of make those solutions for themselves as well, because that's where we see that, like that curve you're speaking of, that the takeaway of the governmental influence also coincides with us regaining our sovereignty back, right? So it's not losing government influence, but it's us gaining our own, taking our own self-determination back again, and allowing our communities to find the solutions our own way that work with our culture and with our people. So yeah, so that's what I think. Marlene, do you have anything to add to that?
Yeah, I will. Yeah, that's a great answer. Self-determination. Yeah, that's really one of the goals. And many of you may be aware or not aware of the current Liberal government push towards co-developing Indigenous health legislation so that we can, have more control over our own health systems. So you may want to look that up and see how the process is going. But another thing is data and data sovereignty. As Kelsie mentioned, there's no year-to-year reporting on data and data sovereignty. On TB cases in First Nations communities. And the way that the arrangements are right now is that provinces and territories send all of the, public health data over to FAC, and then, they sort of work with CIHI as well on hospital utilization rates, and then they get these numbers and so on. But a lot of this data doesn't have any ethnic or race identifiers. And it's, and CIHI and other Canadian institutions have been saying, we need race identifiers, but First Nations are a bit reluctant because they don't want to say, well, I'm a First Nations person, because that might lead to substandard care. It might lead to racism that they're, as an individual, are not empowered to address, right? But there is a whole movement around data sovereignty and getting data that is OCAP compliant. If you want to do more reading on this, you can visit fnigc.ca. That's the First Nations Information Governance Center. And they have a whole roadmap to data sovereignty. So I think that's going to really support First Nations, Inuit, and Métis in gaining control of data, of analyzing that data, and making policy recommendations based on data that is specific and that is clear and that is owned by communities.
Thank you so much. Thank you so much for the question, and thanks Marlene and Kelsie for the response. I'm going to take a pause and move to Stephanie and Pushpita for their talks, and then we'll have opportunity to return to this conversation in a little bit. Thanks again. So it's really my pleasure to introduce you to Stephanie Law. Stephanie has a PhD in epidemiology. I was part of her thesis committee, so it's really nice to see her from here. I've worked with her for several years. She is now a postdoctoral fellow at McGill University after she did a little stint at Harvard's Department of Social Medicine and Global Health. She uses quantitative and qualitative methods to explore the social dimensions of TB care and services. And her current research is focusing on measuring and influencing health workers' trust towards people in TB care in Peru, in South Africa, as well as right here in Nunavik in Quebec. So she's going to tell us a little bit about her work. Welcome, Stephanie. The floor is yours.
Thank you, Amrita. And thank you so much for the great presentation, Kelsie. I think it leads smoothly into what I'm about to talk about. So I will share my screen. Okay. All right, so today I'll be talking about a project that we call Mobilizing and Engaging Nunavik Youth in the TB Video Project. So briefly, a little bit about TB in Nunavik that Kelsie sort of mentioned as well. So Nunavik is a region in northern Quebec, home to nearly 14,000 Inuit. And that's one of the 3 Indigenous groups in Canada. TB, as you know, is more or less eliminated in Canada among the non-Indigenous people. And so we're looking at rates of 0.5, 0.6 per 100,000. Contrastingly, in Nunavik, the TB rate has been rising since 2000, and now we're at over 400 per 100,000 people in this region. So there has been very, very publicly announced goals in Canada to eliminate TB in the Inuit Nunavik and in Nunavik by 2030, which is only 7 years away. So as part of these goals, the Nunavik Regional Board of Health and Social Services has been doing some TB screening campaigns in the last few years to try and get a sense of where TB is in the region and then plan the activities accordingly. To support that work, myself and my team, we qualitatively evaluated a couple of these campaigns just to see how we can make these efforts better. And in order to plan the actions to come afterwards, we want to know where these actions should target. So there are several important themes that came out of these evaluations, and two of them that are relevant to this video project are that first, TB activities are largely led by non-Inuit outside the communities, and this is, where Kelsie and Marlene talked about self-determination. There's really very little of that in Nunavik at the moment. The Nunavik Regional Board does have a steering committee that is led by Inuit. So there is some momentum towards self-determination in Nunavik. But as a result of how things currently stand and historically have stood, there is a lot of issues around trust or mistrust and misinformation about TB and TB services in Nunavik. And then the second thing is that the youth population in particular is very hard to reach. They had a very tough time getting the youth to come participate in the screen campaigns to get tested. And if among those who do get have a positive test, to move on through that cascade of care. And this is against the fact that in Nunavik in particular, TB rates are higher among the youth ages 12 to 16 compared to the rest of the population there. So I have two quotes here from those evaluations that I think kind of stand out when it comes to talking about TB in Nunavik and specifically amongst the youth. So here's a community leader says, "I think the youth could have been made more aware of the dangers of spreading TB. This sickness is worrisome." So speaking to the fact that youth in general have very little information about TB, and some of the information that they are getting is not necessarily correct. So this leader is saying that we need to do more amongst youth. And then another community member said, "We could learn more from Inuit people who know more about TB, then the community, would come more comfortably." So again, it speaks a little bit about self-determination, but a lot to do with the fact that TB care and services and education is still largely led by non-Inuit. And I think there's a general sense in the communities that it would be better and people would be more receptive to the care and services if more of it was led and done by Inuit. So this leads to the video project that we're about to start in Nunavik in a couple of the communities with the youth. It's part of a much larger project to implement and evaluate a community health worker program in Nunavik. I won't really talk much about that project, but as I just said, it is a program to try and train people in Nunavik, Inuit, to lead a lot of the TB health work in those communities. So the objective of this video project specifically is to engage the youth to explore their experiences as well as their community experiences and narratives around TB-related care. So this could be current experiences with TB, but also historical and stories about TB. The method will be following is called video voice. I'll talk a little bit more about that later. And the goal is So this method has been used in other contexts, and in one study, they use that to raise awareness around climate change issues among Inuit youth in the region. It is a participatory approach where the youth will lead and decide what to share in the final videos that they produce. So a little bit about the method and how we'll go about it. We'll start with recruitment and training, targeting youth age 12 to 19. They'll get some training on ethics and like video ethics and research ethics, interviewing and video skills. They'll collect a video footage, and then together as teams, these youth will discuss the footage that they've shared with each other, storyboard the idea, and then finally produce and edit a video as teams. After all that is done, the videos will be shared with the community, particularly the stakeholders and leaders, and also with public health and TB staff. And after that, we'll conduct focus groups with the youth participants, but also people who view the videos to try and assess the feasibility of this project. Can we do it in other communities as well? Whether it was acceptable, and how relevant are these videos for future community health workers in the communities, and as well as non-Inuit TB care workers. So some of the expected outcomes, we're hoping, of course, that this would increase TB awareness among youth participants. We're hoping that these videos would be a more Inuit-led representation of TB experiences in those communities and of the youth in particular. And hopefully these videos will be incorporated into the community health worker training program, and also used to do cultural competency and cultural safety training for other healthcare workers who are non-Inuit and currently and will potentially work in Nunavik. So I just want to acknowledge the support of the Nunavik board, people who participate in those screening evaluations, support the Inuit communities in Nunavik for this project, and also other members of the research team involved. And that's it. Thank you. I don't know if there's time for questions, or if questions will be later, but happy to answer any questions.
Thank you so much, Stephanie. I think we'll take one question. Thank you so much. That was really, it sounds like a super interesting project, very engaging, very participatory. Let's see if someone has a question first before I go on. Any thoughts or comments?
Hi. Yeah, I will just add one, Amrita. It looks like a great project, Stephanie, and I would just suggest to you that you reach out to Mark Terry here at the Dahdaleh Institute. He's a fellow who runs a planetary health film lab that works with Indigenous youth in the Arctic region, in South America, and with more broadly with youth around the world. But we've had several targeted programs that focus on Indigenous youth, and it's on how to use short filmmaking using mobile phones to advance community-based knowledge around the health impacts of climate change. And these films are used not only in community, but in national policy fora, but also international policy fora. So we have some experience that might be of help to you and that you might be able to draw from. So I very much encourage you to reach out to Mark on that. But that was a great presentation, and I look forward to seeing where the research actually leads. Thank you.
Thanks, James. I'll definitely reach out to him. Sounds very relevant, for sure.
Thank you. Thanks, James. Thanks, Stephanie. So if there's any other questions for Stephanie, please put them into the chat box. I wanted to just devote a few moments to Pushpita, our final speaker. Pushpita Samina is working as a program officer at SHIFTB, and she's doing her PhD in health policy at McMaster University in Ontario. She is from Bangladesh and also a physician in training, by training. She worked in global health for over 10 years in organizations, including USAID projects before she came to Canada, including at the WHO and the Southeast Asia Regional Office and several international NGOs, including some based in Eastern Europe. So I'm really excited to have Pushpita here. Without further ado, please tell us a little bit about updates in the social sciences from around the world.
Thank you, Amrita, and good afternoon, everyone. As Stephanie and others have already talked about, there have been a lot of research recently going on in social science and TB. There have been researchers in mental health, stigma, equity, and also access to care. So without further delay, I would like to share some of the achievements that we have done through SHIFTB in the last year. Sorry, some technical glitch. So as I mentioned that our SHIFTB network has grown. In the last year, we have now more than 50 contributors from more than 20 countries. They are the researchers who are working in TB, covering more than say 10 social science disciplines, for example, anthropology, linguistics, economics, history, medicine, ethics, and law. And also we have trainees, TB advocates, science, and people with lived experience of TB. Some of our new contributors are on the screen, as you can see. We are also collecting papers and related research outputs from all of our contributors into a resource page, which you can see on the right-hand side, which now allows visitors to see the social science related TB resources by topic. While it is nowhere like OVID or MBES databases, but sophisticated databases, but still you can see the search is like modified, and it helps us to cut out a lot of potential noise that you might have seen in other searches. We also produce quarterly newsletters to advertise updates and also to showcase some of the original contribution from our people, as you can see on the left-hand side. For example, we showcased how the discipline of anthropology can support in TB, and in February we had an essay on racialized TB epidemics in the United States and also in South Africa. We have also contributed to some exciting events last year. We celebrated International Men's Day with WHO and Light Consortium based in UK. It was our second year consequently. And we also had a workshop in the main union conference on equity and TB. In that consortium, we had great speakers like Grania Bridgeton from the Global Fund, Ernesto Jeremillo from the WHO, Uzma Khan from IRD Global Pakistan, and also a TB survivor, Yulia Chorna from the WHO Civil Society Task Force on TB, and Yulia is also a PhD student here at York University. We also had Shea from University of Sydney. Following this, we also have won 2 related grants. One of the grants was from Brosher Foundation, which is based in Geneva. We are going to arrange a 3-day workshop to extend our conversation on equity and TB. And also we got recently received a supplementary Shark Connection grant to support the travel from the people traveling from Canada and also some lower middle income country, and also the students from Canada. Speaking of students, we also had supported master's thesis through SHIFTB, and this happened at Maastricht University as a part of Shark Partnership Development Grant we won in 2021. 3 of the students undertook a policy analysis of TB guidelines across 7 countries, whereas we collaborated with an advocacy organization which is based in New York called TAG, and to support one of the students' analysis to find the social dimensions of TB within the global TB funding architecture. So that was from me, a quick update, and I go a little bit fast so that we can cover the time. If you have any question, please feel free to ask. Thank you.
Thanks so much, Pushpita. Thank you very much. So that was a super quick snapshot of just some of the work that we're doing in the TB social sciences. And of course, we heard from Kelsie and Stephanie before that. I just wanted to open up the floor for maybe 2 to 3 minutes if there are any questions, if anyone's interested in this sort of stuff, if they have contributions to share. I especially value contributions from non-TB people because it's always nice and refreshing to hear about their view.
Amrita?
Stephanie.
Go ahead.
Hi, thanks for an awesome presentation. My question is more methods related. The video, where am I? Okay. Yeah. The video voice method is quite unique and new. I am interested to know, how did you reach the decision of using video voice? What was the vetting process? Yeah, basically that's my question for Stephanie. Thank you.
Yeah, thanks for the question. Sure. So the idea really originated from the community themselves. So after we had finished the evaluations of the TB screening campaign, we took all the findings back and reported back to the communities. And in the communities, several of the leaders talked about how we really need to get the youth involved in some of these TB activities. And they talked about making videos, and that the kids might really like to make videos. And now everybody's on TikTok and everybody has their phone. So this could be an activity that they can actually really take ownership over and then get very engaged with. As for the video voice specific method, I think it comes again from the fact that we want it to be participatory. We don't want it to be another thing where we go in and be like, hey, do this, but we want to give them kind of general guidance that this is a video that has to do with TB, but it's going to be up to them to decide how to present TB in the communities through these videos.
All right, thank you so much.
Amrita, can I ask a question?
Of course.
Yeah. So I'm just very curious about the global epidemiology and the where your initiatives around the social determinants of health, and in this particular case TB, fit within that sort of effort. So you said at the beginning that some 10.6 million people are infected with TB every year, and about 1.5 million people die every year. And one thing that continues to just profoundly shock me every single time I think about TB is that this is a 100% curable disease, right? We have treatment. It's 100% curable, it's 100% treatable, and also 100% preventable, right? So your initiatives around the societal determinants of health, and in this particular case, TB, can you kind of situate your strategic direction in terms of prevention, treatment, and cure, right? Those three kind of programmatic, if you will, objectives. And I think cure is actually a separate thing. Like it actually requires a separate sort of approach to thinking. And I wonder, would you be able to comment on that?
Yeah, I mean, thanks, James. One of the biggest pieces is that we all, the world knows that TB is a social disease. It's a very sort of old age, it's like this long-standing adage almost that, yeah, we all know TB is a social disease, it's a disease of inequity, but there's no action, there's no concrete indicators or targets to address this framing, right? The framing remains very biomedical. Any actions around TB remain very clinical and biomedical and focused on killing this pathogen or preventing transmission of this pathogen. So when it comes to the prevention discourse, it's really about prevention is not about the drugs and treatment. Prevention is about addressing those root social determinants, kind of the stuff that, you know, Kelsie and others are working on, tapping into some of the things that Stephanie's working on, just looking into how can we actually think about where and how TB has emerged, has persisted, what are the barriers to access, you know, even if tools are available and treatments are available and people are developing vaccines, et cetera, we know that the problem won't necessarily be fixed by these things because there's a lot of social and economic and legal and historic barriers. So that's kind of where I think SHIFTB's work is situated, is amplifying attention to that to complement all of that other advancement that's happening in parallel domains and spheres, which are all extremely relevant and needed. Like, you got to kill this bug and you got to stop transmission. But you have to also address those root social causes, because if you don't, you know those other remedies only hit the surface. They're like, it's almost like the low-hanging fruit are those technological fixes, right? And then when it comes to cure, what is cure? You know, cure is kind of a clinically defined thing, but for people who are affected by TB in communities who experience and deal with TB day to day, cure is like one outcome of so many other outcomes that they might value. Things like stigma, such as, you know, what it means to have lived with it and lived with that taint of TB forever and ever. So that's kind of the stuff we're trying to amplify, James. I know we're over time, so I'll stop right there, and I invite anybody to sort of connect to me, connect to SHIFTB through email or what have you, to extend this conversation. I also wanted to say a huge thanks to the speakers, to Kelsie, to Marlene, to Stephanie and Pushpita, and of course to the Dahdaleh Institute, James, Teresa, Hannah, for supporting this work in this webinar.
Well, you're very welcome, Amrita. And I really enjoyed the seminar, and particularly the presentations, extremely illuminating. You know, I will add that, just in response to your last comment, Amrita, you know, the elimination of polio was, and to a very significant degree remains, a hugely complex task that required real vision, that required an appreciation, a deep appreciation of not only the biology or the virology of polio, but of the societal determinants of health. It also required a mobilization through a story, through a way of seeing a possibility. And I really think there are some real parallels between TB and polio in terms of how human beings could approach tuberculosis as a treatable, curable, and preventable disease. That might be an area of interest for someone, some great academic who has great mental capacity to think about that. And with that, I just thank you again, Amrita, and to all of our speakers. I really enjoyed it. I know everyone really enjoyed the presentation. And our next seminar will be on March 29, next week, and it's with Carol Devine and Yasmin Al-Sahili. And Carol and Yasmin have been working with MSF on or Médecins Sans Frontières, Doctors Without Borders, on a planetary health advocacy framework. And they will be presenting on that next week. So with that, again, Amrita, and to our speakers, I would very much like to thank you. And with that, we'll end the seminar. Thank you very much.
Thank you. Bye all.